therapies. Sir mentioned most of the wounds which do not respond to the conventional dressing and take long time. Negative pressure wound therapy definitely helps in cutting down the length of stay at the hospital and helping in the treatment, and the financial burden also comes down. So there are different products. This will be the industry presentation in the afternoon, but the device which you are using is negative pressure device is the basic one. So these are the range of the things. This is a very handy device. Why I just chose this because when in my practice I use different devices, but this comes to be very handy, easy to carry, and there is a connectivity with the phone also, a Wi-Fi connectivity and Bluetooth, so that you can monitor remotely as well. And a touch screen also is there, and a lock screen wherein the patient accidentally, if he stops the therapy, that's an issue. So that part is also taken care of here. So this all I think everybody is seen here. So you know that foam, and it comes in different sizes for the different wounds. So this is a portable device. So this is with the irrigation. So what the people are doing is, as Sir told in his previous slides, capacity building of the end user. He has a device, he has the consumables, but he doesn't know how to use that properly. So down south, most of the surgeons also, they are not aware of the actual hands-on usage of the practice. So capacity building is more important. What I feel is this is the choice of wound is very important, sir. You should plan it even before you have put your incision first. Like I want to apply negative pressure wound therapy for this particular wound. So even before doing the debridement, maybe you need to plan something like you debride a wound haphazardly and then try to apply the VAC therapy. That might not be feasible. So even before you put your first incision, decide whether you want to go for a VAC therapy. Along with other therapies, your VAC therapy should help you. So you should put a clear margin wherein you can apply the foam and pack it properly, because the leaks of pressure are not allowed here. Like the packing is a key role. So design your wound before only. Like while putting incision itself, you should have in mind that I want to apply VAC here, so maybe this margin I need to have. Okay. Then as I told, consent is a very important thing. Even before that, while choosing the wound, whether the wound is really ready to heal or not, because we just look at the wound, we need to see the general condition of the patient as such. What is his nutritional status, and what is the blood supply there, what is the bone health. So I prefer, like whenever I do that, do an arterial Doppler first, see for the supply, whether the supply is there or not, because granulation happens only if a good supply is there. If it is not there, okay, you don't heal the wound, but you will be causing more damage as well, because we have seen some people who apply without seeing the supply, and infection sets in and it worsens the wound, and definitely that's not a good result. We need to prevent the amputations, the smaller wounds which are there in the foot are there. So our motive should be to prevent the amputations first. So the supply is good, the bone health is good, then you can manage the wound, and maybe the patient can walk later on. So, but here I just got one case from my field wherein the patient came into a septic shock with necrotizing fasciitis, and we had to sacrifice the limb to save his life. But what next after that? Like he had a very big abony amputation wound, which was not healing, and his condition, general condition was not improving with all other supportive measures, and we wanted to drain the wound. Then we applied this VAC for him. This video can, you know the techniques, sir has already told you the technical aspect of that. So the drainage of wound, we applied this for around 5 days for him. So much of collection was there. With the conventional dressing, it would take a lot of laborious work and a lot of dressing material and all that. So all that is also avoided. There is a ease of use as well. Then this was the result of the first setting. So most of the slough has come out and the granulation is stimulated. So the wound is showing some signs of healing. Our aim is how do we close this finally? Because we want a healthy stump wherein prosthetic limb can be put in and then he can probably walk with a support. So then we put a second sitting wherein the granulation was still good. Then the general condition of the patient also was improving with antibiotics and other support. And he was like, I would like to go home and come back, sir, like that. Then we sent him home. And from his home, he just shared a pic to me. You can see the remarkable decrease in the size of the raw area. Now, this is the current picture. Of course, our aim is to close the wound without any pressure effects, and so that he can use a prosthetic limb at the end of the treatment, and maybe a little bit of debulking is required here, and then we can close the wound. So this is the journey of this wound. So initially how it was and finally how it is. So definitely VAC therapy is very useful, provided we do a good choice of the wound and right approach, and as I told, we should take care of the consent as well. All that is. Thank you, sir.
Thank you, sir. You're open for questions.